Imagine for a second that you're holding like a really sharp 30-gauge medical needle,
Mm-hmm.
and your target is this highly specific layer of tissue that's completely hidden from your direct line of sight.
Right.
And this layer is barely thicker than a few sheets of paper.
Uh-huh.
So if you inject too shallow, your treatment does absolutely nothing.
Yeah, nothing at all.
But if your needle slips, I mean, even a millimeter too deep, you pierce a critical anatomical structure. You could potentially cause permanent urinary or structural damage to your patient.
It's basically the ultimate high-wire act in medicine. I mean, you are navigating an area where you have zero margin for error.
Wow.
And you're doing it largely by feel, indirect visualization, and just this really deep, almost instinctual understanding of biomechanics.
Well, welcome to the deep dive. We are so thrilled you're joining us today because our mission for this deep dive is to unpack exactly how clinicians actually pull off this high-wire act.
Yeah, it's intense.
We're digging deep into the highly specialized world of pelvic medicine. And our goal today is to uncover the precise clinical protocols that doctors use to safely deposit platelet-rich plasma, or PRP, near the periurethral plexus.
Right, and specifically we're focusing on how they avoid accidental intra-urethral or bladder neck cannulation.
Exactly. Put simply, how on earth do they avoid puncturing things they absolutely must not puncture while operating in, one of the most delicate, unforgiving environments in the human body?
To really appreciate the tension of this procedure, you kind of have to visualize the terrain first.
Okay.
The medical literature actually draws this brilliant parallel between the periurethral area, so the tissue surrounding the urethra, and the periorbital area, which is the skin directly around your eyes.
Oh, wow.
Mechanically, they present the exact same nightmare for a clinician.
Because they're both incredibly thin?
Thin, yes, but also highly vascular. I mean, they're just absolute webs of microscopic blood vessels.
Right.
And more importantly, the superficial tissue sits directly on top of vital structures. Around the eye, you have the globe itself and the optic nerve.
Right, which you obviously don't want to poke.
Exactly. And around the urethra, you have the urethral lumen, the actual tube, and then just slightly further up, the bladder neck and the primary sphincter mechanism.
Okay, so in both locations, one tiny slip of the wrist doesn't just mean a bruised patient. It means you've compromised a major bodily function.
Precisely.
Okay, let's unpack this. Before we get into the really heavy biomechanics of how they thread this needle, let's establish why they are even taking the risk in the first place.
Yeah, the why is crucial here.
Because we're talking about injecting PRP into the anterior vaginal wall and the periurethral area to treat things like female sexual dysfunction and stress urinary incontinence.
Right.
And for you listening, if you already follow the regenerative medicine space, the use of PRP isn't a new concept. We know they spin the patient's blood down to concentrate the platelets and harness things like vascular endothelial growth factor, or VEGF.
Right.
But what is the actual mechanical goal here? Why risk puncturing the bladder neck just to deliver growth factors? I mean, injecting this area sounds like trying to deliver fertilizer directly to the roots of a delicate plant using a sharp spike without piercing the main stem.
That's a really good analogy, and the reason they do it is because you're trying to fundamentally remodel a failing physical structure.
Okay.
When a patient suffers from stress urinary incontinence, their urethral support system has often just weakened over time.
Yeah.
So the goal of dropping concentrated VEGF into that specific plexus is to trigger massive neovascularization.
Which is building new blood vessels.
Literally forcing the body to build new blood vessels, yeah. And jump-starting collagen remodeling, you're basically trying to rebuild the scaffolding and improve the seal of the urethral sphincter.
Okay, but wait. We have tried to rebuild the scaffolding before, right? Like, urologists used to inject synthetic bulking agents into this exact same area, things like Teflon paste or silicone microparticles.
They did. And honestly, the historical context of those synthetics is exactly why the modern protocols are so terrifyingly strict.
Oh, really?
Yeah, the idea with those older synthetic materials was purely mechanical. Just inject a physical space occupier to bulk up the tissue and squeeze the urethra shut.
But I'm guessing the human body doesn't usually love permanent foreign microparticles just being shoved into its delicate tissues.
Precisely. And that's where the catastrophic complications came in.
Nice.
If a clinician missed the target layer even slightly, those synthetic materials caused massive tissue fibrosis, devastating abscesses, or, and this is the wild part, the material would literally migrate.
Wait, migrate? How does it just migrate? Is it just floating around in there?
It migrates because of tissue planes, and this right here is the core of the entire challenge. You have to deposit the material in what is called the submucosal plane.
Okay, let's visualize that, because submucosal plane sounds very clean and geometric in a textbook.
Yeah.
But I know human anatomy is super messy, so think of the urethral wall like a multi-layered cake. What are we actually looking at?
That's a perfect way to picture it. So the inner lining of the urethra, the part the urine actually touches, is your top layer of frosting.
Okay, the frosting.
That's the mucosa. Just beneath that frosting is a thin, spongy layer of connective tissue and blood vessels. That is the submucosa.
Spongy layer. Got it.
And beneath that is the thick muscular sponge of the cake itself, the detrusor and sphincter muscles.
Right.
You cannot inject into the muscle, and you cannot inject into the top frosting. You have to slide your needle exactly between the frosting and the muscle.
Oh, wow.
Yeah, that incredibly narrow, microscopic gap is the submucosal plane.
So if your needle goes too deep, you pierce right through the frosting and punch into the empty center of the tube. You've cannulated the lumen.
Exactly.
And what happens to the PRP then?
It just immediately washes away. The PRP drains right out of the body through the urethra. You've achieved absolutely nothing, and you've injured the mucosal lining in the process.
That's awful.
But it gets worse. If you angle too far up and puncture the bladder neck, you risk severe voiding dysfunction and long-term damage to the primary valve that keeps urine in the bladder.
Which brings me to a massive point of confusion I had while I was digging into the clinical protocols for this deep dive.
Oh, what was that?
Well, if the target is that incredibly narrow layer of cake, precision is literally everything.
Yeah.
But when I was looking at the training manuals for things like the O-shot, which targets this periurethral plexus, I was looking for the hard numbers.
Ah, I see where you're going with this.
Right. I wanted the exact millimeter depth, like insert 30-gauge needle exactly 3.5 millimeters. But it's not in there.
No, it's not.
The Women's Health Clinic guidelines explicitly state that a precise anatomical target depth should not be published as patient-facing advice. It is this very deliberate non-answer. How do you standardize a medical procedure without a ruler?
What's fascinating here is that you don't, because a ruler implies the landscape is static, and in the pelvic floor, the landscape is violently dynamic.
Wow, violently dynamic.
Human anatomy changes drastically across the adult lifespan. The tissue thickness of a 30-year-old is vastly different from a 60-year-old, largely due to the loss of estrogen.
Right.
Plus, pelvic floor tone shifts dramatically after childbirth. The vascularity changes based on genetics and hormones.
Okay, I hear that. But surely there is some sort of average. I mean, if you are a doctor learning this, you can't just be told, feel it out. It's like asking a pilot exactly how much engine thrust is needed to land a plane.
Whoa.
Like, you wouldn't just say, guess. It completely depends on the crosswinds and the weight of the aircraft that day, right?
Yeah, it's actually exactly like that. It's like navigating a complex river where the sandbars shift every single day based on the current.
Oh, that makes sense.
A map from yesterday is totally useless today. If a medical manual published a standardized depth of, say, 4 millimeters, and a clinician blindly followed that rule on a postmenopausal patient with severe tissue atrophy.
Let me guess. 4 millimeters would drive the needle straight through the urethra and out the other side.
Precisely. Guaranteed puncture.
Ah, okay. The tissue itself literally thins out. So a number that is perfectly safe for one patient is incredibly dangerous for another.
Exactly. So avoiding cannulation isn't about memorizing a number. It is an entirely subjective, clinician-only judgment.
Wow.
It requires physical examination, extensive hands-on training, and most importantly, relying on real-time sensory feedback during the actual injection.
Okay, here's where it gets really interesting. Let's break down that sensory feedback, because this is where the mechanics just get wild to me.
Yeah, it's intense.
They are going in with a sharp needle, completely blind to the external depth. What is their physical toolkit to keep that needle on track?
Well, since they can't rely on depth, they build physical and visual bumpers. The primary physical guide is actually a Foley catheter.
A catheter.
Yeah. Before they even uncap the needle, they insert a standard urinary catheter directly into the urethra.
Wait, I'm stuck on this part. The catheter is inside the urethral tube, but the needle is injecting into the tissue outside the tube.
Right.
How does feeling a rubber tube on the inside actually stop them from piercing the wall? Aren't they still fundamentally flying blind?
It's all about tactile compression and proprioception. By placing the catheter inside, the clinician creates this firm, palpable boundary.
Okay.
So when they introduce the needle, often a 22 gauge or 30 gauge, they don't just jab it in, they use their non-dominant hand to feel the tissue.
Oh, they're physically touching the area.
Yes. They can literally roll the periurethral tissue between their fingers and the solid tube of the catheter inside. The catheter acts as a physical backstop.
That's wild.
They introduce the needle perfectly parallel to the urethra, using the resistance of that inner tube to gauge where the boundary of the lumen actually is.
That is fascinating.
Yeah.
You're essentially giving yourself a rigid wall you can feel from the outside,
Hmm.
turning a squishy, ambiguous tissue into a defined structure.
Exactly.
But they aren't just relying on touch,
Yeah.
right? Because if a puncture is going to cause severe damage, they have to verify visually somehow.
Absolutely. Visual confirmation is the ultimate fail-safe here. And this is where cystoscopy comes in.
Cystoscopy.
Right. While they're setting up the injection from the outside, they are often running a tiny camera, usually with a 0-degree or 12-degree lens, right up into the urethrovesical junction.
Okay, so let me get this straight. They are looking at the inside of the urethral wall on a monitor while their hands are working on the outside with the needle.
Yes.
What exactly are they watching for on that screen?
They are watching for a very specific phenomenon. It's called a bleb.
A blib.
Yeah, a bleb. It is a deliberate, localized tissue bulge.
Okay.
As the clinician slowly depresses the plunger and injects the PRP, they are staring at the monitor. If that needle tip is perfectly positioned in the submucosal plane, that microscopic layer of sponge we talked about, the fluid has nowhere else to go.
Because it's trapped between the layers.
Exactly. It forces the mucosal tissue upward, creating a visible, pale swelling on the inside of the urethra. That's the blib.
Okay, let's explore the physics of that for a second. Why is it pale?
Because as the fluid creates pressure and bulges the tissue out, it momentarily compresses the microscopic capillaries in that specific spot.
Oh, I see.
The blood is squeezed out of the superficial tissue, so it flashes white or pale on the camera.
So that bleb is instant visual validation. You inject, the tissue bulges on the monitor, and you know you are in the exact right layer of the cake.
Exactly.
But what happens if they inject and the bleb just doesn't appear?
The procedure stops immediately.
Instantly.
Instantly. If there's no bleb, the needle is in the wrong place. If they're too superficial, the PRP is just pooling under the skin and it won't reach the vascular network.
Right.
But more dangerously, if they inject and suddenly see fluid weeping directly into the camera's view, they know they went too deep. They've punctured the mucosa.
Oh no, so they've cannulated it.
Right. They have to withdraw, let the tissue settle, and attempt a completely different angle.
Man, the pressure on the clinician to process all this simultaneous feedback is immense. You're feeling a catheter, you're watching a monitor for a pale bulge, managing the depth. And we haven't even talked about the distance rules yet.
Oh, right. The distance safeguards.
Yeah, because there are strict protocols about how close they can physically get to the bladder neck, right?
Very strict. You want to rebuild the support structure near the sphincter, but you have to give the bladder neck a wide berth. The protocols dictate retracting the needle tip and the camera 1.5 to 2.0 centimeters distal, meaning away from the bladder neck before you deposit the fluid.
And from the sources, the placement around the circumference of the tube is incredibly specific too. Like I was reading about injecting at specific clock face positions.
Yes.
Sometimes it's 3, 6, and 9 o'clock.
Mm-hmm.
Other protocols use 2, 5, 7, 10, and 12 o'clock. Why map it out like a clock? Like why not just inject a big ring of fluid all the way around?
Because of the risk of lumen distortion. Remember, PRP stimulates growth and adds immediate volume.
Right, it's plumping it up.
Right. So if you just injected a massive ring of fluid or dumped all the PRP into one side, you would warp the delicate geometry of the urethra. You might accidentally squeeze the tube completely shut, creating severe voiding problems.
Oh, wow. Which defeats the whole purpose.
Exactly. By placing tiny microdeposits at specific symmetrical clock face points, you ensure the structure is supported evenly from all sides without blocking the lumen.
Okay, this brings us to what I think is the most mind-bending part of the entire clinical protocol, like the absolute peak of mechanical precision.
I think I know what you're going to say.
When I was looking at the macroplastic training manual, they detail this really specific maneuver called the tissue tunneling technique.
Yes. The tissue tunneling technique is the ultimate biomechanical safeguard. It basically solves a major physics problem in these types of injections.
Okay, explain the physics problem to me. Because intuitively, I feel like if you stick a needle in and push fluid out, the fluid just stays there. Why is that wrong?
Because you are injecting into a highly pressurized environment. It's kind of like trying to inject jelly into a tightly squeezed rubbery donut.
Okay, I can picture that.
The tissue in the periurethral area is incredibly dense and it's under tension. When you push fluid into that space, you are dramatically increasing the local pressure.
Right?
So the moment you pull that needle out, the massive back pressure from the surrounding tissue is going to squeeze that precious PRP right back out the exact hole you just made.
Just shooting back out.
It'll leak straight out the needle track.
Which completely defeats the purpose. You lose all the growth factors, and you fail to support the structure.
Yeah.
So how does this tissue tunneling thing stop the jelly from shooting back out of the donut?
By creating a physical lock.
It's a lock.
Yeah. Instead of going straight in and pulling straight out, the clinician creates a dogleg tunnel in the tissue. It's a very precise biomechanical maneuver.
Walk me through it.
First, the clinician inserts the needle into the superficial tissue at a steep angle, usually 30 to 45 degrees, but they only advance it a tiny amount, roughly 0.5 centimeters.
So they are just barely piercing the surface crust, angling down toward that submucosal layer.
Right. But they do not inject yet.
Okay.
Once they hit that 0.5 centimeter mark, they completely change the trajectory. They flatten the angle of the needle down to 0 degrees, making it perfectly parallel with the urethra and the internal catheter.
Okay.
And once the needle is flat, they advance it another 0.5 centimeters forward through the plane.
I see. So the entry wound on the surface doesn't line up directly with the pocket of fluid they're creating deeper down.
Precisely. It creates a zigzag or a step-down tunnel. When the needle is eventually removed, the overlying tissue presses down flat against the deeper tissue, sealing off the track.
Like a valve.
It acts as a natural mechanical valve. The back pressure of the tissue actually helps clamp the tunnel shut, trapping the PRP safely in the submucosa.
That is incredibly clever. But man, the physical execution of this sounds just agonizing. They make the dog leg, they inject the PRP slowly while watching for the bleb on the monitor, and they just stop.
Yeah.
The protocol literally says they have to hold the needle completely still for a full 30 seconds before withdrawing.
And that 30 seconds is likely the longest half minute of that clinician's day.
I can't even imagine. Let's really milk the tension of that moment. You are holding a sharp piece of metal inside one of the most vascular, heavily innervated, delicate spaces in a patient's pelvis. Your hands are locked.
Yeah.
Your breathing has to be perfectly controlled. The patient might shift.
It's nerve-wracking.
Why subject the doctor and the patient to that 30-second hold? Why not just pull the needle out immediately once the valve is created?
To let the fluid dynamics equalize. Even with the dogleg valve, if you withdraw the needle the millisecond the injection is done, the peak pressure of the fluid will force it up the track. That 30-second pause gives the local tissue time to expand, stretch, and accommodate the new volume. It allows the pressure gradient between the injected PRP and the surrounding tissue to balance out.
Okay, that makes sense.
Once that pressure drops, the clinician can smoothly withdraw the needle without losing a single drop of the regenerative fluid.
It's just a profound amount of physical and mental stamina required from the clinician. I mean, you are using a Foley catheter as a blind physical bumper, watching a microscopic camera monitor for a white tissue bulge, mapping out symmetrical clock faces in your head, dropping your needle angle from 45 degrees to 0 in a space of 5 millimeters, and then holding dead still for 30 seconds while the tissue pressure equalizes, all to avoid accidentally nicking a tube that is fractions of a millimeter away.
It's total mastery. But it also highlights a glaring reality about all of this. Even with flawless technique, a sharp metal needle is an inherently violent instrument. Needles carry an unavoidable risk of tissue trauma. Every time you poke the mucosa to create those clock face deposits, you increase the risk of inflammation, scarring, or accidental cannulation. You are relying entirely on the perfect steadiness of human hands.
Which naturally makes you wonder, if the needle is the source of the risk, is anyone figuring out how to do this without one? So what does this all mean for the future of these treatments? Can we deliver PRP to the submucosal plane without piercing the tissue with metal?
We are actually getting very close. There is a fascinating development currently being studied that could make this entire needle protocol obsolete.
Really?
Yeah. Researchers are testing pressure-controlled water jet technology.
Hold on. When you say water jet, my mind immediately goes to heavy industry. Like, I picture those high-pressure streams of water slicing through thick sheets of steel and granite. How does that translate to the incredibly fragile environment of the bladder neck?
It sounds crazy, but it relies on the exact same fundamental principles of fluid dynamics, just scaled down to an incredibly gentle microscopic level. Right now, this is being heavily tested in live pig models, whose urological anatomy is very similar to humans. And instead of using a sharp, rigid metal tip to tear a hole in the tissue, this device uses a high-velocity microscopic stream of liquid.
So the fluid itself is the needle.
Exactly. The device uses highly calibrated instantaneous pressure to push the cells and liquids directly through the superficial mucosal layer, depositing them right into the submucosa.
Wow.
There is absolutely no physical instrument entering the tissue wall.
I can see how that bypasses the risk of puncturing the bladder neck. I mean, there's no metal tip to accidentally drive too deep. But mechanically, how does a blast of fluid behave differently in the tissue compared to a needle injection? Does it still create that clustered bleb we talked about?
That is the most exciting part. It doesn't cluster.
It doesn't.
No. When you use a needle, you are forcing a pocket of fluid into one localized spot, which is why we see the bleb. It's essentially a pool of liquid. But the studies on the water jet method show that the high-velocity stream actually disperses the injected compounds.
Disperses them how?
Instead of a pool, the fluid sprays outward horizontally once it hits the correct plane. The studies observed that after several weeks of follow-up on the animal models, the injected cells were beautifully and evenly dispersed throughout the urethral mucosa.
That's incredible.
Yeah, they were sitting perfectly adjacent to the sphincter muscle.
But that is exactly what you want for regenerative therapy. You want the VEGF and the platelets spread evenly across the entire scaffolding, right? Not just dumped in a concentrated puddle at 3 o'clock and 9 o'clock.
Precisely. It maximizes the surface area for cellular regeneration. And crucially for our deep dive today, it completely eliminates the peril of accidental intra-urethral cannulation.
Because there's no needle to go too far.
Right. And you aren't leaving physical puncture tracks for fluid to leak back out of, so you don't need to perform complex dog-leg tissue tunneling. You don't have to hold your breath for 30 seconds waiting for pressure to equalize.
Now, obviously, this is still in the animal testing phase. Bringing a high-velocity water jet into human trials involves rigorously proving that the pressure won't inadvertently cause a different type of tissue shearing.
Sure. Yeah.
But the potential to take the sharp metal completely out of the pelvic floor is revolutionary.
It is a massive paradigm shift. But until that technology is perfected and widely available, patients rely entirely on the mechanical brilliance of the clinicians performing these injections today.
And what a masterclass in navigation it is. To wrap this all up, we set out today to understand the clinical protocols doctors use to safely deposit PRP near the periurethral plexus without puncturing the bladder neck.
Yeah.
And what we discovered is that safety in this incredibly delicate, highly vascular area isn't found on a ruler. It isn't a standardized depth measurement.
Not at all. It is a highly dynamic, multisensory process. Clinicians use Foley catheters for tactile compression, cystoscopy lenses to watch for the exact color change of a submucosal bleb, and complex biomechanical maneuvers like tissue tunneling to trap the fluid. It requires an intimate understanding of tissue pressure and shifting human anatomy.
Understanding these protocols really empowers you, the listener, to see beyond the clinical jargon. Whether you're a patient considering regenerative therapies for incontinence or just someone fascinated by medical mechanics, it gives you a profound respect for what doctors casually refer to as minimally invasive. I mean, it might be minimally invasive to the body, but it is maximally demanding on the human performing it.
Absolutely. It is the art of reading invisible terrain in real time.
We have spent all this time exploring the meticulous, physical skill required to wield a needle safely near the bladder neck. The steady hands, the 30-second pauses, the perfectly angled dog-leg tunnels. But it leaves me with one final thought for you to chew on.
Ooh.
If pressure-controlled water jets soon become the gold standard, successfully taking the needle entirely out of the equation, will the defining surgical skill of the future be less about a surgeon's perfectly steady hand and more about their mastery of fluid dynamics? Thanks for diving deep with us.